So with us today is Bill Maroon. He's the Business and Organizational Development Specialist for Resources for Human Development. For the last 10 years, Bill has worked as an internal consultant for Resources for Human Development and Business, Program, and Organizational Development. From 1993 to 2007, he worked directly with persons experiencing homelessness in various settings, including street outreach, shelters, and housing. In 2003, Bill was the clinical director for the first Housing First program developed in Philadelphia as a part of the pilot project through the Federal Interagency Council on Homelessness. Now I'm going to leave it off to Bill, who's going to introduce the rest of the presenters. Bill?
The Secretary, Department of Human Services, and Christine Sigmariglia, CEO of Pathways to Housing. We're going to start off today with just giving a little bit of an overview of how deep this crisis is and what this epidemic is really becoming for those folks who may be new to this area. 2015 was unfortunately a record-breaking year for drug overdoses. The increase is coming from opioids and heroin. Unfortunately, 2016, it looks like those numbers are going to break the 2015 record. And as people may know, since 2000, when the first set of prescription drugs for painkillers was introduced, deaths from overdoses have increased over 500%. Unfortunately, in 2014, 89% of the folks who suffer from substance use disorder did not receive treatment. So access is definitely an issue. Jason will get into some of the stats around Pennsylvania, but Pennsylvania continues to rank in the top 10 of drug overdoses in the country, and almost 40% of folks requesting and getting into drug rehab are coming in for heroin. That's the third highest in the country. Jason's going to let us know what's happening at the state, what the governor's planning to do and has done to address the issue, and give some more statistics around that. Jason?
Thanks, Bill. I want to first thank the Housing Alliance of Pennsylvania for putting together this webinar. Certainly very, very timely topic, as we are in the midst of the worst ever overdose death epidemic that the Commonwealth of Pennsylvania or the nation have ever seen. Again, my name is Jason Snyder. I'm a Special Assistant to the Secretary of the Pennsylvania Department of Human Services. I'll talk to you a little bit today about, again, what the governor is doing, especially his signature response to the epidemic. First, though, as Bill suggested, I want to provide some additional context to you. Again, this is the worst ever overdose death epidemic that Pennsylvania has ever seen. It's the worst public health crisis of the last 100 years. In 2014, depending upon what numbers you looked at, about 2,700 Pennsylvanians died from drug overdose. The majority of those deaths were opioid related, heroin and prescription pain medications. In 2015, we saw about 3,500 deaths to drug overdose, which was about a 23.45% increase over 14. 2014 was a record. Obviously, 2015 was a record. And although the final number isn't in from across the state for 2016, we expect to see anywhere between 4,500 deaths and as high as potentially 5,000. When you look at the counties that have already reported the number of drug overdose deaths from 2016. It is not a stretch whatsoever to believe that we could see a 40% increase in deaths in 16 over 15. It was not too long ago that automobile accidents were the #1 cause of accidental death in the Commonwealth. At 3,500 deaths in 2015, that translates to 10 a day. We see about 3 people die every day in Pennsylvania from automobile accidents, and so at 10 a day, drug overdose deaths have far overtaken automobile deaths as the leading cause of accidental death in the state. I come at this position from both a professional and personal standpoint. As I had mentioned, I am the special assistant or a special assistant to the Secretary of the Department of Human Services. My primary role in this position since I came to the Department of Human Services in October of 2016 has been to oversee implementation of the governor's signature response to the epidemic, which is the Centers of Excellence, and I'll talk a little bit more about that in just a couple of minutes. Prior to my position here at the Department of Human Services, I was the communications director for the Pennsylvania Department of Drug and Alcohol Programs, and I did that for, again, about a year before I came to the Department of Human Services. I also come at this from a personal standpoint as well. I was raised the oldest of 3 boys in Cambria County, Pennsylvania, lifelong Pennsylvanian, to parents who are still married to each other today. They'll be married to each other 46 years this September. By all measures, we were a typical middle-income, blue-collar, Western Pennsylvania family. My dad provided us with everything we needed, most things we wanted. My mother was a stay-at-home mother. Certainly it was a different time when we were being raised than it is today, but we never really talked about or thought much about drug addiction, and certainly overdose death was inconceivable. Yet, as we got older, drug addiction took center stage in our lives. We watched for many years as my brother Todd spiraled deeper into his addiction. At age 28, January 24th, 2005, age 28, Todd died of a heroin overdose. I was actually the second person on the scene there and made what to this day has been the most difficult phone call I've ever made, and that was to my parents to tell them that Todd was dead. And it set off a chain reaction of wailing, as you can imagine. First my dad, then my mother, and my youngest brother, Josh, who lived at home at the time. I could hear him in the background as well. We were shocked. We didn't think this would happen to a family like ours that was raised the way we were and that had the kinds of opportunities that we had. Back then it was something that happened to quote-unquote those people. So though we knew death was a possibility for Todd, it still was a shock. So when it happened again a little more than 2.5 years later, we were really dismantled. This time, the brother I mentioned, Josh, who I could hear wailing in the background at the news of the death of his brother Todd, Josh at age 25 was dead of a heroin overdose. September 14, 2007, my mother called me that morning to tell me that Josh was dead. November 14, 2007, exactly 2 months later, Josh's son was born. And so obviously he will never know his father. As I said, we were dismantled. This family into which so much had been invested was really blown apart and left me as the last man standing, so to speak, the last living child of my parents, which made it all the difficult for me in 2011, late 2011, to tell them that I was entering inpatient drug rehab for an addiction to prescription pain medication, something that capped many years of drug and alcohol abuse. Fortunately for me, my story and path so far have been much different than my brother's. And I've been given the great opportunity here with this administration under Secretary Dallas and Governor Wolf to use not only my personal story but also my professional experience to really advance the treatment system and transform the treatment system. And that's really what we're looking to do with the Centers of Excellence. As I had mentioned earlier, this is the governor's signature response to the opioid epidemic, a $20.4 million effort to essentially integrate behavioral health and physical health care and improve the quality of care that people with the disease of addiction receive. There are 45 Centers of Excellence, 45 existing healthcare providers have been designated as Centers of Excellence. They were designated as such through an application process. We received about 116 applications. 45 of those were chosen as Centers of Excellence. Each of those centers has received $500,000 to, again, improve the quality of care that people with the disease of addiction are receiving, in large part by integrating physical and behavioral health. We actually have 2 of the 45 Centers of Excellence represented today as presenters, both Resources for Human Development as well as Pathways to Housing are Centers of Excellence, and I won't steal any thunder from my co-presenter who will follow me, but I will talk more about Centers of Excellence in general. The initiative was born in part after we looked at Medicaid data for the state of Pennsylvania from 2014. And that data showed that of those Pennsylvanians covered by Medicaid who were diagnosed as having an opioid use disorder, only 48% got into treatment. Only 48% got treatment. Of that 48%, only 33% remained engaged in treatment beyond 30 days. And we know, as the evidence clearly indicates, that length of stay in the continuum of care, and that continuum includes everything from residential treatments to halfway housing to intensive outpatient and partial hospitalization to outpatient. Length of stay in that continuum of care is directly correlated to recovery from the disease of addiction. And so when we looked at that data, we clearly saw that we were not doing a good job of getting people into treatment, nor were we doing a very good job of keeping them engaged in treatment. And so the overarching goal of the Centers of Excellence becomes just that: improve initiation into treatment and retention in treatment. And there are really 3 objectives that we have outlined that will help us to achieve that overarching goal. Number 1, as I mentioned earlier, is to treat the whole person. Not just treat the individual's addiction, but treat any underlying physical health or behavioral or mental health issues that may be contributing to or driving the addiction. I remain very connected to the recovery community. It's an essential part of my ongoing recovery. And by the way, today I do identify myself as a person in long-term recovery from the disease of addiction, which for me means that I have not had a drink or a drug, a mood or mind-altering substance in little more than 5 years. And remaining connected to the recovery community is essential for me to stay on the path that I am on. And in doing so, I have had opportunity to meet many, many people. And I often tell the story of a young woman who I've come to know. She is 21 years old and has been through 8 stints in rehab. She began injecting heroin at age 12, and her mother is addicted to alcohol, and her father sexually molested her as a child. And so we ask ourselves, how is it that she could have gone through 8 rehabs and still be struggling with the disease of addiction? And the answer is, we've not treated the underlying trauma that is really, in many ways, at the root of the addiction. And so if we don't treat those underlying issues, the likelihood that we're going to have success in treating the addiction is low. And so objective number 1 of the Centers of Excellence is to treat the whole person, integrate behavioral with physical health services. So how are we going to do that? That's where the second objective comes in. We're going to do this through a community-based care management team. I mentioned earlier that each of the 45 Centers of Excellence have received $500,000 in funding. The majority of that funding is to be used to hire community-based care management teams that will provide services that are otherwise not reimbursed by Medicaid. So these community-based care management teams are charged with meeting individuals wherever they may present in the system. The Centers of Excellence are really charged with developing a hub-and-spoke model, if you will. The center is the hub, and the spokes coming off of that hub may include health systems, emergency departments, primary care clinics, the criminal justice system, housing agencies, really a vast array of spokes coming into and out of the Center of Excellence. And so the community-based care management team is charged with meeting individuals wherever they may present in that hub-and-spoke model so that they get a level of care assessment as immediately as possible and that they are placed into the most appropriate level of care as quickly as possible. The care management team is also charged with supporting the individual as he or she moves through that continuum of care, making sure that the transition from detox to inpatient or from inpatient to intensive outpatient is smooth. And also, when it becomes appropriate, ensuring that that patient is supported and connected to other social supports that we know are necessary as individuals recover from the disease, including housing, including employment. So the community-based care management team is expected to do all of these things, and it's really expected to do a third thing, and I'll use that as my transition to our third objective, and that is to expand access to medication-assisted treatment. The evidence clearly states that medication, when provided appropriately, can keep people better engaged, longer engaged in treatment. Frankly, it keeps people alive. And those medications include 3 FDA-approved medications to assist treatment: methadone, buprenorphine, and naltrexone. Many of you may know buprenorphine by the brand name Suboxone, and many of you may know the drug naltrexone by its brand name Vivitrol, which is a long-acting injection. We know, again, that the use of these medications, from methadone to buprenorphine to naltrexone, it keeps people alive, keep people employed, keep people meeting their responsibilities, reduces the potential to spread HIV and hepatitis C. These medications are demonstrated by research to improve outcomes and lengths of stay in treatment. And so, really, those are the 3 goals or objectives, as I've called them, of the Centers of Excellence in order to achieve that overarching goal, which, again, is to better initiate people into treatment and to keep them engaged longer in treatment, provide quality care, and really begin to transform a system that can begin to reverse what has been a rising and very troubling trend in overdose deaths over the last several years. With that, I think at this point I will hand off to the final our final presenter, and be happy to answer any questions I can for you. Thanks very much, folks.
Thanks, Jason. I just wanted to follow back. RHD is a recipient of the Center of Excellence grant, and our formerly named methadone clinic in Norristown, Montgomery County Methadone Clinic. It has allowed us to kind of revamp that program to be the Montgomery County Recovery Center, and it's allowing us to increase our case management and to keep people engaged beyond that 30-day initial period. Our stats kind of show that once somebody sticks with us beyond that 30 days, 92% remain off of illegal drugs if we can keep them after that 30 days. I'm going to introduce Christine in a second. I just wanted to highlight our other program that has existed in New Jersey, in CAMDEN, New Jersey, as a pilot program since 2008. It serves 25 individuals at a time, and it is for people who are actively using opiates and heroin, and it's a housing first program. So people come into the program actively using, and they are offered Medicaid assisted treatment and a safe needle exchange. We've had some amazing outcomes from that program in the last 9 years. We've maintained 97% housing retention. People have voluntarily gone into treatment, and are probably one of our most amazing statistics that came out of this that we didn't kind of foresee was that 98% of the folks who have come into the program who were seeking family reunification, seeking to get their kids back, were successful in reuniting their family. To date, we still have no overdoses, and we at one point we had 47% of our participants in supportive or market rate employment. Some of those people have since graduated from the program, but at one point we did have that rate. I'm going to introduce Christine to talk about Pathways and what they're doing around a very similar project here in Philadelphia. Christine?
Thanks, Billy. Thank you, everyone, for joining this call on a very chilly Friday afternoon. I want to thank Jason again for his willingness to tell his story. Telling our stories is so important as we work to address this epidemic. And I find that so many people underestimate how heroin abuse is touching their lives because they don't tell or hear their stories. I lost my niece in 2013 to heroin. My niece was beautiful, talented, brilliant, middle class. Part of my family still does not talk about her death as a heroin death, and they haven't dealt with that. And I find that whenever, I'm in this business, and so I talk about heroin these days a lot. And whenever I talk about the epidemic and the services at Pathways, I talk about my niece Lauren. And I am surprised that when I bring up Lauren, people get this look on their face, and they say, oh, and then they mention somebody in their family that they've never talked about. And then, the stories bring out other stories. And I just wanted to say that because I think the stories are important because they get buried sometimes in our families, and we don't talk about them. And people then go around with this feeling that heroin is not touching their lives, or people don't know that heroin touched their friend's life. And so the stories are important because it adds faces to these numbers, and these numbers are becoming so overwhelming that we need to not look at the numbers, but we need to look at the numbers as people. And they're people with lives, and they're people with families, and they're people who had futures and talents. And it makes such a difference when we look at that and then take those people and those stories and apply that against how we're looking at treatment. In Philadelphia, and I'm going to talk particularly about Philadelphia because that's what I know and that's what I do, people are dying at an alarming rate. So the numbers thus far that we have for 2016 have shown overdoses spiked with over 900 overdose deaths in 2016 in Philadelphia. I'm on the homeless death review for the coroner's office in Philadelphia. It is not a fun task. You think jury duty sucks? This really is a task that is difficult. But it's necessary because we look at every death of every homeless person and we look at what the causes were and how things might have been different if we had done things different. And the amount of deaths that we're talking about that are due to heroin is skyrocketing. In 2016, there were more than twice as many deaths from overdoses as there were from homicides. And believe me, in Philadelphia, there were a lot of homicides. Philadelphia's Kensington neighborhood is ground zero right now for the purest and cheapest heroin on the East Coast. So we're not only trying to serve Philadelphia residents, but we're also trying to deal with, serve, save, keep alive people from all over the country who are coming to Philadelphia for the heroin. We want to be number one, but not in this area. The question that we used to ask when we're talking about treatment for people with addiction, especially with heroin addiction, was how do we get people interested in treatment? That question has changed. The question now is how do we keep people alive until we can get them interested in treatment, and then how do we create enough treatment slots for the people that need them? The game is changing, and we need to be on the cutting edge. So why Pathways? Let me tell you a little bit about Pathways. Pathways to Housing is a housing first program. We first opened in Philadelphia in 2008, and our contract, our job at that time was to develop a program to serve 125 people who were chronically homeless and had serious psychiatric disabilities. And they were people that, for the most part, had flunked out of every other program in the city or had stayed under the radar. But they were folks who weren't being addressed. And we have had remarkable results with those folks. Since that time, we've tripled in size. So we're now serving over 400 folks in scattered site apartments all over the city with a modified assertive community treatment approach. A lot of those folks have heroin addictions. So what we found was that we were already serving 40 folks with major heroin addictions, and the demographics for those folks looked a little different, but the outcomes for those folks looked very much like the outcomes we were seeing with our base population of people with mental illness. So we wanted to serve more folks that needed treatment in a housing first program. We have an 89% housing retention rate after 5 years with some of the most difficult to serve people in the city. And more importantly, those people, the people that have been in our program for a while who have a dual diagnosis with a primary heroin addiction haven't died. Similar to Billy, we look at these statistics and we're like, these people haven't died in our care. And that's a big deal looking at the amount of deaths that we're seeing in Philadelphia with heroin and the awful fentanyl cuts and everything else that's going on. So we decided that as an agency, we were in a position to expand what we do in a way to address the growing heroin epidemic in Philadelphia. We applied to HUD for subsidies, and we were granted in the last round 60 Housing First subsidies, and we worked with the city's Department of Behavioral Health to match those subsidies with services. So we have 60 subsidies, and we have matching services in a modified assertive community treatment model. We also have, on a very small scale, we had some primary care services as a satellite site of an FQHC that Project Home runs, which is another homeless service provider in the city. We applied for a grant from the Substance Abuse and Mental Health Services Administration that we were granted. We actually got the SAMHSA grant at 2 days prior to getting the Centers of Excellence grant. And that has expanded our ability to provide primary care services. So we now have primary care services available to a population that really doesn't connect well with medical care 5 days a week. And a lot of those services are provided on the streets. So we do a lot of street care. And then we're using the Centers of Excellence grant in partnership with Project Home and Prevention Point in Philadelphia to provide medication-assisted treatment. So we have 3 agencies that came together to work on expanding treatment options outside of the typical treatment environment. So Prevention Point does case management and needle exchange and harm reduction services in Kensington. So we're using some of the money to expand the treatment services that they were providing in Kensington. Project Home has just started providing medication-assisted treatment in their clinic environment in North Philadelphia. And we're using some of the money to expand their services. And then we're using some of the money to create and expand treatment services at our clinic, at our offices in North Philadelphia, and also on the streets and wrapping around the 60 people and plus additional that are coming into these apartment units. We use a harm reduction approach that encompasses needle exchange, Narcan disbursement and training, along with education and treatment in bringing services to the street. We have, as part of this movement toward trying to holistically deal with the folks that are homeless and addicted and hungry and tired and lost in this neighborhood in Philadelphia, we have looked at how do we address all of those things, because people aren't ready for treatment, people don't want treatment, people have been kicked out of treatment. So how are we keeping them alive until we can get them ready for treatment? And then, as part of the Centers for Excellence, how are we developing treatment slots so that we can, when people are ready, connect them. And then once they're connected, keep them motivated and keep them connected. We're very grateful for both Governor Wolf and Secretary Dallas's vision in our getting one of the Centers of Excellence grants. Because our partnership with Project Home and with Prevention Point, we look weird compared to most treatment programs. So, we're kind of 3 organizations that were not big treatment organizations. We were big harm reduction, housing, medical care organizations that wanted to grow treatment, because we're organizations that are connecting with people, and we are in places where the folks that need the services are. And this grant is helping us to look at providing treatment and the ancillary services that need to wrap around treatment to people in a different way. So I'm actually going to end that there because I always find that answering people's questions is much more valuable use of time on these presentations than just continuing to talk at you about some of the things we're doing. I left a slide that's got some information about me. I'm always willing to answer stuff after the fact or connect with people, so you can catch us there. And I'm going to turn it back to Billy. Thank you.
Thanks, Christine. So, I think our experience, along with Christine's experience at Pathways, definitely shows that housing is healthcare, and that using scattered site supportive housing approaches can work for this population, can keep them engaged, can keep them alive, and can offer them an opportunity to engage in treatment. One of the things that we noticed through our recovery center in Norristown is that when somebody is couch surfing or somebody is homeless, they can't fully engage in medication-assisted treatment. One other thing that I just wanted to bring up before we get into questions is this new idea. It's not new for the world, it's really new for the United States, is this new innovative approach around supervised injection facilities or consumption sites. There are about 100 supervised injection facilities around the world, and none as of yet in the United States. The political will hasn't been there, or the understanding hasn't been there how having supervised sites for people to bring their drugs to a place, potentially get it tested so that they know what's in it, use and in a safe place, safe needles, and then be observed coming down off the drugs in case there's an overdose. In 2016, Boston Healthcare for the Homeless opened up an observation site. You can't come to that site and use, but you can use before you go to the site and come there and be observed coming down off the drugs. However, a couple weeks ago, the mayor of Seattle announced plans to do the first 2 supervised injection sites in the United States. They're called community health engagement locations, and I'm hopeful that there will be other political will around the country to try this controversial but innovative approach. So we wanted to open it up to questions. You can use the chat, or you can, I think we're going to, Tori, can you unmute everybody? Is that how we're going to do this?
The conference has been unmuted.
I know.
Well, we said there's the link to with stuff.
Yes.
The conference is unmuted. Just
Hello?
a reminder.
Have you heard it? Have you heard it?
Havana night, yeah, that was stupid.
Oops.
That was stupid.
To mute if there's background noise, please. Does anyone have any questions?
The only ones that have worked out really well.
I have a question. It's I just wanted to thank the
Will you
presenters.
like John Wick?
You know what, Tori, I think you might have to
somebody
mute
put
everybody.
the right to know
That style.
House member,
The conference has been muted.
So now you
So
need
I
to.
am actually just going to have people type their questions into the chat box. There's just too many people on this call to kind of control the background noise. So if you just have a question, if you could please put it in the box, that would be great.
Hey,
Hi,
Tori,
Tori.
this is Chris. I'd like to actually add something while people are doing their questions.
Okay.
If that's okay. I'm glad that Billy brought up the supervised injection facilities, because it's something that at Pathways we're very much in favor of. And I'll tell you another thing, another reason why. So as we look at a heroin epidemic sweeping across the state, it brings with it a lot of other issues, not just people dying from heroin. So when there's a lot more people using heroin, there's a bigger need for needles. And if you don't have enough clean needle exchange programs, you're going to have people using not so clean needles. There is now a market in Philadelphia for needles, not just clean needles, but works of any kind. So it means people are using a lot of needles that are not clean. When we have people using needles that aren't clean, we have an increase in HIV. When we have an increase in HIV, and we have an increase, when we have an increase in the use of dirty needles, for people who, in a lot of ways, try to get the money they need for their habit, and in Philadelphia we see a lot of that as sex work. So you have people that are using unclean needles and now doing sex work. So you have an increase in HIV, not just among the people who are using, but among people that are buying sex. And then you have an increase in HIV outside of that community. And so we are really scared to death because we're looking at an increase. We're looking at HIV for the first time in a long time exploding again as a public health crisis in Philadelphia. So I just wanted to add that little tidbit as to what some of the ripple effect is to this epidemic. Thanks.
Great, thanks, Christine. Just a reminder for people, if they want to type some questions or share experiences that they have going on in their communities, the chat box is on the left.
Tori, can you hear me?
Yes.
So it's Joyce. Folks can also do *7 to unmute just themselves. I just had one, and I wanted to say this has been a great conversation and presentation. Thanks. If folks could, Jason or Bill or Chris, talk about how case managers or people throughout Pennsylvania can access the Centers of Excellence, that would be helpful.
Hey, Jason, do you want to talk a little bit about the website? Because you guys have a really great website that has all the center's contact information on it.
Just a reminder, *7 to unmute, Jason.
Okay, can you hear me?
Yes.
Okay, great. So if you look at the slide that I reversed back to, you'll see there on the third bullet a URL. It's actually pretty lengthy. So if you just go to our website, dhs.pa.gov, you can also navigate to a section of the website that will provide you points of contact at each of the 45 Centers of Excellence. These are phone numbers and contacts for people who are actually working day to day on the Center of Excellence. These are the people you would talk with about getting someone into treatment, so they're good contacts. They're going to be folks who can answer your questions. Again, there are 45 Centers of Excellence spread across the Commonwealth. I don't know how many counties that represents. There's obviously not one in every county, and in some counties you'll find multiple Centers of Excellence. Of course, Philadelphia and Allegheny counties, the number 1 and 2 most populated counties in the state, are going to have several. I believe there are 6 or 7 in Philly, and I know there are 6 in Allegheny County. But again, if you go to our website and you take a look at that list of Centers of Excellence, you'll be able to see where they're located across the state, as well as get contact information for the sites, and you can get some good information there. I would also suggest that the single county authorities, which are essentially county-level drug and alcohol administrators, administrative organizations that receive funding from both the state as well as from a federal block grant to provide prevention, treatment, and intervention services. These agencies also can connect you either to a Center of Excellence or to other treatment providers in your area who can help you. Again, these are called single county authorities. In lay terms, I would say county-level drug and alcohol administrators. If you go to the Department of Drug and Alcohol Programs website, you should be able to find information there for connecting to a single county authority. And of course, if you need any help, I'm more than happy to help you as well. My email address is not on one of these slides, but I'll give it to you now. It's jssnyder@pa.gov. That's jssnyder@pa.gov. So I hope from those couple of resources you can certainly get plugged into a center of excellence or at least a provider in your area. Thank you.
Great. Thanks, Jason. I think you did address this question, but Karen was just wondering if there's no center in our rural county, will another county take one of our residents?
Sure will. There's no exclusion, I guess you could say, for a center of excellence, or I should say nobody is excluded from using a center of excellence that may be across county lines. So if you are in a county that has a center of excellence in a neighboring county, certainly that's going to be an option for you. So no question that individuals, if it makes sense and can best provide those treatment services, center of excellence in another county certainly can work.
Part of the beauty of those grants is that there were not residency requirements written into them.
Great. I have one question from Brian. How do the residents pay their rent, and how do you find landlords who are willing to buy into the program?
So that actually is more of a Housing First in general question than a Center of Excellence question. It is people pay 30% of their income toward their rent. HUD funds the rest. If someone's income is zero, then 30% of zero is zero. So they don't have a rent requirement, and then it's our job to help them increase their income so that they can increase their portion of the rent. With our program, with our Housing First program, we actually, I think, operate differently than a lot, and that has helped us to not have difficulty finding units. We include landlords as part of our community. We do regular events for our landlords, training and networking events, and they know that if they call us, if there is an issue with someone in one of their units, we respond very quickly. And a lot of the folks, so we rent in low rent neighborhoods, and a lot of folks that live in our landlords' buildings look very much like our clients, but sometimes they're not connected to anyone, and if the landlord has an issue, they don't have anyone to call to help them. And a lot of times we will respond even for folks that are not necessarily our clients because it helps that relationship. And so it's about relationships. It's about building relationships with landlords so that they see themselves as part of your program. Because the reality is, with all of the issues around homelessness and mental illness and addiction, people really want to help, and they don't always know how. And so part of our job as providers is to offer people opportunities to help. And you know, renting to us is one of those opportunities, and that's how we market it.
Thanks, Christine. I have a question from Tony. If Christine can elaborate more on the health care that is taking place on the streets, was additional staff hired to accomplish this goal? For those active substance abusers in housing, what are the main issues presented by this population, and is using taking place in the units?
Okay, that's a bunch of questions.
Yeah.
Yes, we hired additional staff. That was part of the Centers of Excellence goal, was to hire teams of staff that would work on connecting people with treatment. So we have treatment staff along with staff from the clinic and along with staff from our modified assertive community treatment team. So they're all working together, providing services, some on the streets where we're connecting with people, some through our partner in Kensington, which is Prevention Point, some in our offices, and some in people's apartment units. we are a harm reduction program. So that means, yes, we serve people who are actively using and we house people who are actively using. It's been interesting for us figuring out ways to weave treatment into a harm reduction model. And what we found is that we just keep offering, and it's there for people when they're ready, and they know that it's there for them when they're ready. This does, however, present issues, and people, I'm sure, use in their units. Our job in a harm reduction program is to work with people around reducing harm, and that may be reducing their use, not necessarily ending it until they're ready to do so. It is safer for people to use in their own unit than it is for them to use on the street. We have people that overdose on the streets on a regular basis, but we also have people that use and are out of it and then are robbed or raped or murdered. So it's all about reducing harm for us and then getting to a point where a person is ready for treatment, and we do things to reduce harm. Trying to think what else to say about that. I mean, we're learning as we go along. One of the main issues presented is that people are actively using, and we need to work around that. A lot of the folks that we're working with in Kensington, they get up, and then they do whatever they do to earn some money, and then they cop, and then they use, and then they're out of it for a little while. And we've had to actually build a timetable around when people are kind of done with that early on in the day, connecting with them when they're coming out of it, because that's the best time to connect with people, to work on case management issues, to work on making sure they've eaten, making sure they've connected with healthcare if they have some healthcare issues, and talking about treatment, talking about family, talking about all of those things. So it's a little bit of a different timetable, and we're learning that as we go along.
And sometimes we have to have, in our CAMDEN program, a frank discussion about what does safe use look like for you. Yeah. Because having 5 people come over to use is going to threaten your housing at some point. Having one person come over may be the best thing in case something happens where somebody ODs or something, and giving people the tools to use in case things happen, like giving them Narcan, training them on it. But having those frank discussions and not saying you need to stop, but saying what does safe use look like for you, and how will you know you're ready to not use? How will you know you're ready to try treatment? But having those honest conversations that are non-judgmental has led people to treatment eventually.
And also, the other thing that I should say is harm reduction doesn't mean anything goes. We're very clear with people that there are always going to be consequences for your actions. Shooting heroin, buying heroin is against the law. If you decide you're going to start using heroin in the lobby of your apartment building or in front of the kids who live downstairs, you're going to get arrested, and that you're going to have to deal with that. And that's part of the consequences for your actions. And we're also very clear about that. We don't see the consequences as always being a bad thing. Sometimes people need to have consequences. It generates a little thought. And that's for any of us in anything that we do.
And one of the biggest things that happen when people go inpatient for treatment and they're homeless, the biggest thing in the back of their mind is, where am I going to go after this? And sometimes having an apartment there waiting for them makes their treatment more successful.
Yep.
So we have 2 more questions. I think we have time to get them addressed. We have one from Karen. How long is the wait? I'm not sure, Karen, if you're referring to the Centers of Excellence or the Housing First programs, but that's the question from Karen.
On the Centers of Excellence, there should be no wait. Of course, we hear anecdotally in some areas of the state there are challenges in getting inpatient treatment beds. And so if that becomes an issue, we'll work through that. But generally speaking, an individual who needs treatment through a center of excellence can begin to receive those care management services right away. So there should not be a wait. If there is a wait because the level of care assessment has determined that an inpatient stay is the most appropriate level and we can't find a bed immediately, there will be some wait. But generally speaking, you should be able to begin to receive COE services almost immediately.
Can you
But
hear
I
me?
suspect there may be some more to that question.
Can you hear me?
Yes, we can hear you, Karen.
Okay, that's my biggest concern because we're rural. We're Columbia County. We're rural, and we have a huge epidemic. And my concern is that we don't. And I haven't looked at the list. I don't know where our center of excellence would be close to Columbia County, but it's the waiting period that bothers me because you can't get these people into a rehab fast enough, especially when they don't have insurance.
Well, there are a couple of centers of excellence around Columbia. There's one in Montour, Geisinger, and there is one in Luzerne, Miners Medical. Miners Medical is a narcotic treatment program, and the Geisinger folks are working with drug and alcohol partners, as Geisinger, as many of you know, is the health system, and the mix of centers of excellence includes both licensed drug and alcohol providers as well as physical health providers. There certainly is anecdotal evidence that getting into beds, especially in rural areas where there is a lack of treatment providers, can be a challenge.
Yeah.
I would say in those instances, the single county authority is a great resource for you. The other thing I would say, and this isn't going to happen immediately, but the reality is we're probably never going to see the number of beds created in this Commonwealth to address what is believed to be the need today. In other words, to build that kind of infrastructure really is probably not realistic. And what we need to begin to do is look at other ways that folks can receive treatment. It is unacceptable to me and certainly to this administration that somebody who is ready to go into treatment is told, well, call us back tomorrow, we'll see if we can get you in.
Right.
That's completely unacceptable because in many instances we're sending people out to their deaths.
Yeah.
Rather, we need to begin to look at more innovative ways to treat those individuals who say, I'm ready to begin treatment. That includes ambulatory detox programs, for example. Rather than sending somebody home and saying, suffer and wait, we need to begin immediately detoxing that person on an outpatient basis and with a care management team, ensuring that they have the supports that they need until they can get either into a bed or into an intensive outpatient program. I would add that the care management teams also include a portion of those care management teams include certified recovery specialists or peer specialists, and these individuals are in place in large part to support individuals peer-to-peer. They've been where that individual is, and so we're not going to be able to address immediately the need that we're seeing in some areas for beds with beds, but I would say that the centers of excellence, and many of them are already beginning to do this, they're saying, how can we ensure that someone who wants treatment today can begin that process rather than us simply telling him or her to go home and call us again in 24 hours. There are innovative ways to do that. Buprenorphine can help individuals begin to stay comfortable and detox without necessarily getting into a bed. And we have to begin to look more and more at that. We can't simply throw our hands up in the air and say, oh, not enough beds, and send somebody potentially home to their death. And so these are the things we're trying to do to address that. But again, I would say the single county authority in Columbia should be, because they have their finger on the pulse in Columbia, should really be able to begin directing patients to where they have the best opportunity of getting immediate treatment.
Okay, thank you.
Sure.
Great, thank you. So we are out of time, but we just, I think if you quickly can answer Hillary's question, are there any age restrictions on the supportive housing programs, such as CAMDEN, supportive housing pathways, Housing First, and the Centers of Excellence?
I believe in New Jersey it is 18 and over in that program. However, we do end up serving families, and we end up serving people who are under that because we reunite families and people have kids after they're with us. But I don't think they can get in if they're under 18.
And it's the same at Pathways.
And the Centers of Excellence are intended to treat adults, not adolescents. But I would suggest that if you do have an adolescent in need of treatment, while the Center of Excellence itself may not be able to provide that treatment, certainly it's worth a call to the center to talk through your particular scenario, particular issue, and begin to get connected to the right folks who can provide that treatment.
Great, thank you so much, and thanks everybody for getting on this webinar to listen to it, and thanks to the presenters. This was very interesting and a great webinar. So I hope everyone has a happy Friday, and just a reminder that we will send out the PowerPoint and also the recording either today or beginning of next week. Thanks again. Have a good one.
Thank you.
Thank you.
Bye-bye.
Thank you. Please stand by.